Alright, let's get back to where we get to acrocyanosis is where we are. Alrighty then. Well, now I can't remember if I punched the red button. Let me check. Well, let's just start it. Yes, I pushed the red button. It's nothing worse than not pushing the red button. I just came back from a meeting, so bear with me, guys. Acrocyanosis. Acrocyanosis is when you see blotchy or mottled color over the extremities. Usually the hands and the feet appear really cyanotic, and this is normal. And it's intermittent over the first 7 to 10 days. Remember, we talked about how when they need more energy, more oxygen for metabolic needs, the peripheral vascular system is constricted. So that's why the hands and feet are blue, and that's normal. It's not a sign to call the doctor. It's not a sign to do anything. Now, if they get past 2 to 3 weeks old and they still have acrocyanosis, then you might want to be concerned about it. But over that first 7 to 10 days, this is a normal thing that's going to be going along. So, don't get too concerned about acrocyanosis. One thing I did forget to talk about is immunity. I did talk about it, but I didn't emphasize that they don't have those natural barriers developed until they're about 4 to 6 weeks old. So they are really at high risk for infection. So we want to be sure and watch that. I know I just threw that in there so you already know it's important. All right. So how do we distinguish between true cyanosis and acrocyanosis? What if the baby actually has a cardiac problem? His feet and hands are blue because of a cardiac issue. Rub the sole of the infant's feet. Usually the sole will turn pink. The discoloration is caused by the acrocyanosis. So if the sole turns pink, you know that that's what it caused it. If it doesn't turn pink, it's usually true cyanosis. Usually acrocyanosis will disappear when the baby cries and gets all that circulation going and oxygenation going. Harlequin sign or harlequin color is really interesting, where actually 1/2, and I'm talking 1/2, you could take a ruler and draw it halfway from the top of the head down to between their legs, and they will be one color on one side, usually a deep red color on one side and a normal color on the other side. It's not uncommon, so it's a common occurrence. Be sure you document it. You don't just let it, oh, they had a harlequin sign, how cute, and then don't say anything about it. You need to document that this actually occurred. So acrocyanosis is normal in a newborn. Yes, that's absolutely true. It is normal. Cyanosis is not, but acrocyanosis is. All right, let's talk about the skin, integumentary. Desquamation. This is the peeling. That's what desquamation means. You usually see this with post-maturity. So when you have an infant who's 40, or a neonate whose gestational age is over 42 weeks, you will normally see peeling of the skin, which is called desquamation. Now, after a few days after birth, a term baby will start peeling. But usually right at birth with a post-term baby, you're going to see desquamation. Teach the moms not to use harsh soaps. Don't overuse the lotion, and don't rub it all off. They can cause infections by rubbing it all off and exposing the baby skin to environmental bacteria. So be sure that you're teaching moms about that and not to overuse the lotion to try to make it look better. It has to come off. It eventually will come off, but the new skin has to develop underneath it. So they just have to learn to live with it. Other things that we are going to be seeing are Mongolian spots, stork bites, strawberry marks, port wine stain, and erythema toxicum, which is also known as a newborn rash. You may also see a caput succedaneum. This is when you have a pump knot on the baby's head, and it will cross the suture lines. Then reason you need to know it crosses the suture lines is that when you have a cephalohematoma, which looks a lot like a caput succedaneum, the cephalohematoma will not cross the suture line. The cephalohematoma is actually blood between the periosteum and the skull, so it doesn't cross the suture line. So I needed you to know the difference between it and a caput. Usually a caput succedaneum is caused by using a vacuum extractor, and the cephalohematoma is caused by trauma such as being pushed up against the pelvic bone. So let's look at some of these skin disorders, so to speak. So what marking is that? You will normally see this marking in Asian, African Americans, and Hispanic. Usually races of dark skin, you will see these markings, and this is a Mongolian spot. It doesn't necessarily have to be on the buttocks. It can be on anywhere on the body, but normally where you're going to find it is going to be on the buttocks. Okay? This poor little baby has a port wine stain. It is permanent. There are things they can do for port wine stains, but they are not cheap, for one thing, and they're not as efficient as you'd like for them to be. Laser surgery is what they have been, they can use to try to diminish how the port wine stain looks. But it's going to be a permanent mark, and even if it does fade in time, if there's any emotional changes of the infant, it will usually change colors. And it does persist into adulthood. And like I said, laser surgery is about the only thing you can do about it. Do you recognize this? This is actually a hemangioma, or a strawberry mark. And first, these were really considered benign, but and they're usually are supposed to shrink over time. But recent research has shown that we really need to be monitoring these hemangiomas because some of them do enlarge. And if they was to be ruptured, some kind of trauma happened that this hemangioma ruptured, they are very vascular and they can lose a lot of blood through these hemangiomas. So we need to monitor them frequently. So what about the reproductive system in the babies? Oh, in fact, one of the things about reproductive system in the males is that they can actually develop hydrocele, which is fluid in the scrotum. You can take a flashlight and actually put it up under the scrotum, and it shows a very fluid-filled sac. And if the testes are descended, they're just floating around there in the fluid. So it's really amazing to see. With the female, we've already talked about pseudomenstruation. You're also going to see some edema and some bruising possibly, especially if they've been a breech presentation. You're going to see a lot of bruising around their perineum area. You'll see a lot of edema. They have a lot of edema in their labia. And sometimes if they're premature, they don't have complete coverage. So the labia doesn't cover. But in a normal newborn, you may see some edema, and it looks like they have an enlarged labia, which they really don't. With our males, you want to make sure that the testes are descended, both of them. So in your initial assessment, you should be checking to see if both the testes are down. If they do not come down within a couple of days or so, you need to have especially before discharge, the parents need to be taught to check for that. Because if the testes do not descend, this male can lose his ability to father children. So you really want to be sure that they're educated about testicles that have not descended. Penis, we want to be sure we're checking the penis, around the glans penis, for hypospadias. We're checking to make sure where the meatus is. We want the meatus to be right in the center of the glans penis. If it's on top, it's hypospadias. So You want to be sure that you're checking for hypospadias. If they do have hypospadias, you don't want to do a circumcision until they've been evaluated because they may not be eligible for circumcision. So your pediatrician or your obstetrician who normally do circumcisions at the hospital should not do this until a urologist has been consulted. We can see swelling of breast tissue in both sexes, male and female, simply related to the hyperestrogenism of pregnancy. Mom has a lot of estrogen during her pregnancy, and it can cause breast tissue to swell in both male and female. You can also see in both male and female what they call witch's milk. They will actually leak some colostrum from their breast, and again, that's due to that hyperestrogen that's of pregnancy. You may see some epithelial pearls that's on the tip of the prepuce of the penis, and that's a normal thing to see too. Be sure that if you can't tell if it's a male or a female because of an elongated clitoris, if you're not for sure what it is, you want to be sure and report it to the doctor. Sometimes it looks like a female with an elongated clitoris, and it's actually a male who does not have descended testes or scrotum. They may not have any female reproductive organs inside. So you want to be sure and report it to the MD so they can decide, where we're going with this. Then we want to assess the musculoskeletal system. This is where we're going to start looking at all those reflexes as well. So at term, the baby's head is 1/4 that total body length. So that tells you that the head is a very instrumental in heat loss. So you want to keep it covered. So if you want to cool a baby off, the head's a place to go. If you want to warm them up, cover their heads up, because that is 1/4 their total body length. Their arms are slightly longer than their legs, makes them look kind of like monkeys, and their legs are 1/3 of their total body weight. If they happen to have extra digits on their hands and the feet, it's polydactyly. If they happen to have fused fingers or toes, that's syndactyly. Usually this is a familial thing, runs in generations. I know there is one student in our traditional program that she was born with 6 fingers, had it cut off. Her child was born with 6 fingers, had the 6th finger removed, and her mother had a 6th finger. And used to it was if you were born with 6 fingers, you were a witch. So, gotta watch those things. Be sure you're inspecting the soles of the feet for creases. Right at birth, you can actually tell gestational age. If they don't have any creases or very, very few creases in their foot, they're premature. The increasing number of creases correlate with greater maturity. So if the whole sole of the foot was covered in creases, then they're term. If they're covered with deep creases, they're probably a little post-term. This has to be done within the first couple, 2 to 4 hours, because after that the skin begins to dry out and the creases begin to develop on their own. So you want to be sure that if you're going to be using the sole of the feet, you should do it right after birth. Look at the sole of the foot and determine if you're not for sure what the gestational age of that baby is. So you're going to inspect the hips for symmetry. Your skin folds should be equal and symmetric. So if you have 3 skin folds on one side and 2 skin folds on the other hip, chances are you have hip dysplasia. So you want to make sure that you're inspecting them. You can also do the ortolani, which is that you can put their, and we talked about this in physical assessment when we were talking about musculoskeletal, how you can put the infant's knees up and then push outward, and if you hear clicking in the hips, then that's usually hip dysplasia. You don't want to do that unless you've been trained to do it, because you can cause hip dysplasia if you're not careful. You want to make sure that the spine is really straight and easily flexed, that there's not anything going on there. You want to make sure there's not a dimple at the base of the back, a Polonial dimple at the base could be indicative of spinal bifida, even if it's not an actual visual spina bifida. If there's a dimpling or a little tuft of hair there, it could actually be indicative of that. So you want to be watchful to make sure that the spine is nice and straight and clear. Newborns should be able to lift their head and turn from side to side when they're prone, when they're laying on their tummy. Sometimes they're born with clubfoot. We'll talk more about clubfoot in depth in musculoskeletal peds in the summer. But usually with clubfoot, the foot turns inward and is fixed in a plantar flexion. Sometimes this is related to in utero position. If it's related to in utero position, you will be able to easily turn it back into the position it should be in, although it will not stay. So it'll be easily fixed, whereas if it's actual clubfoot, you will not be able to turn it back to the position that it should actually be in. The neuromuscular system, we're talking about the brain. Of course, when we talk about the brain, we're going to talk about the skull that it's in. Remember the two fontanelles that we have, the anterior and the posterior. Anterior closes at 18 months, back closes at 6 to 18 weeks, or 6 to 8 weeks, pardon me. What you want to be watching for is that normally with fontanelles, you can actually see the pulsation of the pulse coursing through the brain, and it's not abnormal to be able to see the pulsation. And it should be, the fontanelle should be level with the skull. If you have bulging, then that's usually a sign of either fluid overload or hydrocephaly. If it's sunken, that's a sign of dehydration. So those are things you really want to look at and look for. Brain growth is going to continue up until early childhood. It's more gradual through that first decade. It's very rapid during that infancy and early childhood. You see all these advertisements for DEA that should be given to them by the time they're age of 3, the growth of the brain is complete. Well, it's not actually complete. It's just when the most rapid portion of the growth of the brain occurs. More gradual through the first decade of life and then minimum through the adolescence. It's very vulnerable to nutritional deficits and trauma, like shaken baby syndrome. And of not having enough formula, not being getting enough protein, getting fed more water than it should be. So it's very vulnerable. So we need to be very careful about the infant skull. If we see tremors, we've already talked a little bit about tremors. They're transient. Usually during crying episodes, they shake and tremor, and their mouth will tremor, and their chin will tremor, and we'll say, "Oh, how cute! Look at his little trembling chin." This is usually normal if they're doing all this little crying episodes, but it shouldn't be present if the baby's quiet, and especially not after they're a month old. So you want to be sure that we're assessing past that point. Okay, newborn reflexes. You have newborn reflexes on page 541 to page 544 in your textbook. Be sure and take a really good look at those and the physical assessment for them. Anytime you have an absence of a newborn reflex that should be there, it's indicative of neurological problems. Anytime you're doing any type of reflex on anybody, if it's not what it should be, it's abnormal and it's a neurological issue. You may not know exactly what it is, but it is a neurological problem. So what reflex is this? Y'all are so good. Yes, that's a grass reflex. And I found this little table that I thought might help you. And so I put it in about the reflexes, how you stimulate that response, what the response should be, and how long it lasts. So let's look at the Babinski. We did the Babinski on adults, right? When we did our physical assessment. The response on an infant is that the toes fan out and the foot twists in. So we know that this is a normal response for a neonate. They should disappear at 9 months to a year. So if that actually has a positive Babinski after this age, there's something neurologically going on. Blinking is a reflex that we all have. And it's a permanent reflex. Hopefully, we always have blinking to help protect our eyes. We just looked at the grasping one, where you touch the palm of the hand, touch the palm with something. You can actually touch the upper portion of the sole up underneath the toes, and the toes will curl and try to grasp. So usually the grasp responses also can be elicited at the foot, but normally we elicit from the hand because that's where we expect to find a grasp reflex. The automatic reflex will weaken at 3 months and then will disappear at a year. When you lay your finger in a 1-year-old's hand, they will not automatically just grasp your finger. Moro is a sudden movement from loud noise. Sudden movement or a loud noise will elicit the moro, which is a sudden movement. It startles, symmetrically throwing out the arms and the legs and then pulling them back. And this usually disappears in 3 to 4 months. Rooting, stroke the cheek. They should turn toward the source where the stroke's coming from, and it should disappear in about 4 months. The stepping syndrome, they look like they're dancing. When you hold the infant upright with the feet touching the ground, he will move his foot as if he's trying to walk, and it'll disappear in 3 to 4 months. Most of these will disappear in 3 to 4 months. Swimming, we don't recommend that you try this one. The tonic neck is also known as the fencing reflex. When you put them on the back, they turn their head to the right, and then they develop a fencing tonic neck reflex. So you can see how he's got his head turned to the side. He's made his fist, but he's extending this arm, and he also is pulling up this leg. So this leg and this arm is distended, whereas this side is not. And here's your grasp reflex, here's your step reflex, and here's your crawl reflex. So what reflex is this one? Yep, that's a Babinski, positive Babinski. Disappears when? About 9 months. I think it's totally amazing what babies can do. Okay, so now we're to physical assessment, where we have to actually assess our babies. These are the things we need to look for when we go in to do our initial physical assessment of a newborn. First of all, we do a general appearance. We can't do an interview of the baby, but we can do a review of systems with the mom of the labor, the delivery, what went on there, so that we'll know how it's going to affect our physical assessment with our infant. We're going to make sure we're checking the posture. We measure the head to be sure about the head size. We want to check to see if there's any lanugo present, if there's any fine downy hair on the baby. Vernix caseosa tells us a whole lot. If there's a whole lot abundant, he's probably premature. If there's not hardly any there, he's more term or maybe even past term. The breast tissue, we're looking for any of the swelling that might be there. We're going to check those creases on the sole for maturity in the first couple hours of birth. What state of alertness are they in? What type of cry do they have? What's our umbilicus? Our umbilicus should be in the center of the body. Our neck's going to be short. Our belly's going to stick out. Usually our baby's in general flexion. Validation of the patent anus is passage of meconium, although sometimes a rectal temperature you'll be able to get meconium on the end of your thermometer probe and be able to say it's patent. But when you're checking your little check box and it says patent anus, you don't want to mark that unless you have visually seen meconium. Always do the apical pulse to check out arrhythmias and murmurs. They have six states of sleep. They go from a really deep state of sleep to just an irritable light sleep, and whatever else is in between. Their vision, they can usually see 19 centimeters away from their face. They are attracted to face and patterns. They like black and white patterns. They really can't discern colors, although we like to give them brightly colored things because they eventually will be able to. Hearing is similar to adults at birth. If they do have deafness noted, its most common cause is infection that has occurred transplacentally. They have a very high sense of smell. They can actually tell their mom's breast milk from the smell of another woman's breast milk. They have two forms of taste. They have sweet and bitter. That's why you can put just a teeny touch of sugar in their water, and they just go to town on sugar water. They love sugar water. They definitely respond to touch. Most of them will respond to touch positively. They like to be touched. Although you do have the drug babies that are doing drug withdrawal, they do not like to be touched at all. So you want to be sure that you are documenting any response to touch that is abnormal. They can habituate to just about any environment, which is awesome because babies are born into all kinds of environments. Again, when we were talking about the blood pressures, you should do both arms and legs. Note any discrepancy that's more than 10 millimeters of mercury, because that signifies coarctation of the aorta. If you want to know what coarctation of the aorta is, it's in your maternity book, and you can look at that. We'll be talking about it when we're talking about pediatric cardiac. But anytime you have a blood pressure discrepancy, you always want to look for some type of cardiac issue going on. Babies lose about 10% of their birth weight, and a lot of that's insensible water loss. And they usually regain their birth weight back by their 2-week checkup within about 10 to 14 days. Sometimes breast babies take a little bit longer regaining their weight back, but once mom's milk comes in, they more than catch up. You want to measure that head at the widest part of the occipital frontal diameter. You want to do the tape measure right at the infant's eyebrow and measure it both in centimeters and inches. The chest is usually 2 centimeters less than the head circumference. Sometimes it's not always, because sometimes you have your little football players where when you have shoulder dystocia, sometimes the chest is either the same size or a little bigger, and you really don't want that because that's a difficult delivery. But normally it's about 2 centimeters less than the head circumference. You put the tape at the nipple line to measure the chest. So you put it at the nipple line and go around the chest. Most of your initial assessments don't include abdominal circumference, but it should be done, especially in preemies, if you may be suspecting they may have some feeding issues and may develop necrotizing colitis. The babies can actually develop that, so you want to necrotizing enterocolitis. There, I knew there was another part of that word. You want to measure just below the umbilicus. The abdomen should be cylindric, and it should protrude slightly above the chest. The head and the neck. Usually, African American babies have larger anterior and posterior fontanelles, so it's not unusual to see a larger fontanelle with these. So don't get alarmed if you see a little bit larger fontanelle with your African American babies. Be sure you're looking for symmetry. You want the baby's face to be symmetrical. I had a baby born that absolutely cried and looked absolutely normal when I laid it down and to actually start inspecting it. The whole left side of the baby's face was totally different than the right side of the face. It didn't have, it had a white socket where the eye should be. It had a nub for an ear. The nose was not complete on that side, and it was really definitely not symmetrical. Be sure that you have your gloves on when you insert your finger to assess for the hard and the soft palate. It's easy to assess whether there is a cleft palate in the hard palate, but the soft palate is further back in the throat, and sometimes it's a lot harder to assess by inserting your finger, and you may need to actually shine your pen light into the throat to see if that soft palate is intact. Assessing for the red reflex is fairly easy to do. You assessed for the red reflex in your adult patients. You just place the pen light directly in front of the pupil and then turn on the light. And then you should see red reflex bilaterally. You will have transient strabismus and nystagmus until they're about 3 or 4 months old. And you'll also see doll eyes, where when their head lags back, their eyes will actually lag back with it. So you may see doll's eyes. Be sure you're looking at the ear, making sure that it's symmetry. If it's not aligned with the inner and outer cavia of the eye, it could be a sign that the baby may be a Down's baby. So you want to be sure and inspect those ears for symmetry and in alignment with the eyes. Make sure you're assessing for patency of the nares. It's when you take one finger and you hold one closed, and then make sure the mouth, of course, is closed, and see if they're breathing through the nares. If you can't tell if they're actually breathing, put a little drop of water at the nair that you're going to not occlude, and when you occlude the other one, that little drop of water should go up into their nair, and you'll do the other one the same way. You can also drop down an NG tube, which I don't recommend unless you have to do suction on the baby because there's so much mucus and stuff going on. You can actually elicit the sneeze reflex by occluding both nares. The baby should sneeze. If you have excessive saliva, you want to be sure and alert the doctor because there's a possibility of tracheoesophageal fistula or esophageal atresia. This is when, long years ago, they used to just give them water to test to see if they had tracheoesophageal or esophageal atresia because they didn't want them to aspirate the formula. Don't do that anymore. Of course, we're going to make sure that we're checking our reflexes and be sure we're grading our reflexes. Of course, it's really hard to, with these grading these reflexes, it's either it's positive or it's negative. There's not a +1, +2, +3. It's either it's there or it's not there. Be sure you palpate the clavicles because there might be some, especially if it's a large baby, if it's been a large baby or shoulder dystocia or a breech delivery, you may have some broken clavicle. If you feel grating or uneven movement when you move the arm, or you feel a lump or a mass in there, then you need to alert your doctor that an x-ray needs to be done to check out the clavicle. We don't remove the cord clamp off of the umbilical until it's dry. Usually it's dry within 24 hours. Some of the hospitals are still using triple dye, which is a purple dye that you put on the belly button, and it's triple antibiotic in there. It's hard as heck to get off your hands. It'll wash right off the baby, but it's hard to get off an adult. A lot of hospitals have gone to just alcohol and letting them dry, and the latest research is it's okay to get the baby's umbilical cord wet as long as you dry it and you don't soak it. So soap and water has been being used as well and letting it dry. The theory is that the umbilical cord is supposed to rot off, and if you put an antibiotic on it, you are preventing the bacteria from causing the umbilical cord to actually dry up and be ready to fall off. Be sure you're looking for moistness, redness, and any really bad odor. If they don't smell really good during the process of the cord rotting off, of course they don't. But if it's a really horrid smell, you need to notify the doctor. Most umbilical cords fall off in 10 to 12 days, but they usually do not heal until about 1 month of age. So they need to be taught that even though the cord will fall off in 10 to 12 days, it's going to be about a month before it's actually healed to where you can say that there's no longer an entryway into the baby's abdomen through the umbilical cord. They're going to eventually start staying awake more. Over the next 3 or 4 weeks, they usually will start staying awake more and more. They will sleep approximately 17 hours a day with periods of wakefulness gradually increasing. And as most moms will tell you, usually most of their awake time is during the night when you're trying to sleep, which is why you try to encourage mamas to be sure and sleep when the baby's sleeping, because they may not get a full night's sleep if they don't sleep when the baby's sleeping. Usually by about the 4th week of life, babies start staying awake from one feeding to another. So when you first take them home, you feed them, they go to sleep. You don't wake up till they're ready for their next feeding. But by the time they're about a month old, they'll be staying awake and you'll feel like you have to entertain them. And this is when good bonding occurs, when you can teach them a lot of things about trust and mistrust, um, and being able to interact with them. They don't really achieve adult sleeping patterns until they're about 4 to 5 years of age. When people say they would like to sleep like a baby, they mean a newborn, a neonate that's sleep 17 hours a day. They don't mean this baby that's going to be awake all night long. They're not talking about that. All right. They can see 7 to 8 inches, which is just the right distance from the mom's face to the baby's face when the mom is breastfeeding, and when she cuddles the baby, and when she bottle feeds him. So this is actually a built-in automatic, I can see you and you can see me while we're doing nice things together, so we can actually bond together. Infants are very sensitive to light. They've been in a dark spot for a long time, so they're very sensitive to light. At about 5 days of age, they're really attracted to those black and white patterns. They'll track their parents' eyes. And when that amniotic fluid gets out of their ears, which it's in their ears, their hearing is similar to adults. And we do those hearing screens now. We usually, you don't want to do them right after they're born, because you want that amniotic fluid to drain and get out of their ears so that they will actually pass their hearing screen. Babies love to listen to their daddies talk because they have low frequency sounds. They decrease motor activity. Sometimes they'll stop crying. Mamas usually alert them. Their high frequency sounds voice alerts them, causes them to wake up more, causes them to cry a little louder, because they know that it's mama, and they know that that high frequency sound is coming from her. Of course, they respond to the touch. It's an essential part of their normal growth and development. Babies who have been left in cribs have a lot of issues of attachment and emotional attachment, physical attachment. They have all sorts of problems if they're not exposed to touch during their infancy. And again, we're talking about their smell already. We have babies with different types of temperament. You may know which one your child is. There's 3 of them. There's the easy child that everybody loves because they're easy. They pee and they poop and they don't puke, and they adapt to change very easily. If you're sleeping in their bed, or they're sleeping in the crib, or they're sleeping in your bed, they adapt to change readily, and they're always in a positive mood. The slow to warm up baby has a little bit of issues with their regularity in body function. They usually withdraw from new stimuli. They don't like new stimuli. It takes a little bit for them to get used to. It takes them a while to adapt. And usually they're a little bit negative in mood. They're not always happy and smiley and ready to see you. They'll give you that little dirty look when you look at them. And then we have the difficult child who pukes and has diarrhea or constipation, and nothing settles on his stomach right, and the milk doesn't agree with him. He goes from one extreme to another. He's either screaming, screaming, screaming. Everything he does when he reacts is intense. His startle reflex is intense. Usually very negative in mood. Very resistant to any change or new stimuli. And likes to cry real loud for long periods of time. So you may find yourself identifying with one of these children. Habituation is a protective mechanism that all infants have that help them become accustomed to their environment. The response to any type of stimuli that's repetitive or constant usually becomes decreased. So that's habituation. So the first time you do it, they may giggle. The second time you do it, they may smile. Third time you do it, they just look at you. And fourth time you do it, they just look at you. So that's basically what habituation is. They can actually habitate to whatever's going on with them. It depends on their state of consciousness, their hunger, their fatigue, and their temperament. You know, if you have a baby that you've got a noisy home, you got lots of kids in it, there's always something going on. If you make everybody be quiet while the baby's sleeping, and then of course the noise is going to erupt and happen, then they're not going to habituate. But if you just continue to do your normal activities during this period of time the baby's sleeping, the baby will eventually habituate to that, and he will sleep through whatever goes on in your household. Um, Crying usually has about 5 different characteristics. Um, it progressively increases to a peak in the second month, and then it starts decreasing. So they cry more and more up until about the second month, and then they'll start decreasing. They have a rhythm, a diurnal rhythm is present. A lot of times they cry a lot more in the afternoons than they cry in the mornings. And babies, you may have a baby that maybe cry once a week. You may have a baby that cries all day long. It just varies considerably. Um, Even day to day, it varies. So you just can't, you will eventually learn what the baby's crying means, and you will respond to it, and you guys will have language all into yourself, because you'll know exactly what they want. I want to be changed. I want to be fed. I want to be held. I just don't know what I want. So, and their crying just doesn't seem to make any difference. They'll cry the same for mom as they do for dad, as grandma, as the babysitter. It really doesn't seem to make any difference between the caretakers, if that makes you feel any better. All right, next chapter, care of the newborn, nursing care of the newborn. APGAR scores. Y'all have already learned about APGAR scores, but let's talk a little bit more about them, because you will have them on your test. It indicates the physiological state of the neonate at the time of birth. It's not something you go by to do resuscitation. You go by what you see. You know, if your baby's not breathing, you don't wait to do the APGAR to find out if you should resuscitate. You do it. So it's based on heart rate, respiration, muscle tone, reflex, and color. We do a APGAR score 1 minute after birth. We do one at 5 minutes after birth. And there are timers on the island, so you can push the button as soon as they're born, and the timer will start, and you will know when it's time to do your 1 minute APGAR. Heart rate, all of these 5 things are worth 2 points. You can have up to 10 points on an APGAR score. So 0 to 3, if your total is 0 to 3, you have a severely distressed infant. This is your total APGAR. If you have a 4 to 6, you have a moderately difficulty distressed infant, and then or one that's having moderate difficulty in transitioning from intrauterine life, and then 7 to 10, you're not having any problems. If you have a 6 or below, you should always do a 10-minute APGAR. So let's look at this baby. Baby's got a heart rate of 136 and respirations of 30. So according to your table in your book, I should have put you a table in here, I'm sorry. We have color. Let's just go there. Heart rate, we got 136. That's a 2, right? Respiration's 30. It's not below 30, so that's a 2. So what else do we have? Color. So if we look at the baby, he looks pink. His belly looks pink, but look at his hands. His hands are slightly blue. So his hands being slightly blue, we know that we're going to just give him a 1 for his color. Irritability, he's definitely got the crying business going on. He's very showing a lot of irritability there with the snuffled up, wrinkled up irritability nose. And his muscle tone is good, because look how his arms are being held and his knees are drawn into his legs. So he's got a 2 there and another 2 there. So we've got 2 for heart rate, 2 for respirations, 2 for color, 2 for muscle tone. 1 for color, 2 for muscle tone, and 2 for reflex irritability. So that's what? A 9. All right. So you'll be able to do that when you see something like this on your test, right? Yes. And please feel free to please look at the APGAR score in your book so you'll know exactly how to score it. All right, what's our responsibility once that baby's born? Of course, we have to do the ID. If you don't ID the baby before it leaves the delivery room, you're in big trouble because it can be switched anywhere without identification. You don't really know who that baby belongs to. So before it leaves the presence of its mother, where it was born, it's got to have the identification bracelets placed on. We try to minimize the interference with our parent-infant acquaintance process by doing everything we possibly can in the room with the mom. Let mom hold the baby while we're doing all this. You can put the ID bands on while mom's holding the baby. Put them on the baby, put them on the mom, put them on the dad, and anybody else who happens to be privileged to pick the baby up from the nursery. Initial baths usually postponed until the temperature is 97.6 and maintained for at least 6 hours. This is what your book tells you. I know there are some facilities that bathe the baby before that 6 hours is up. And they really shouldn't because thermal regulation isn't established until the baby's about 6 to 8 hours old. Be sure to keep them either in a side-lying position. Of course, we don't do this anymore, but if they are having a lot of drainage, a lot of spitting up, they need to be in a side-lying position. Other than that, they need to be on their backs. That's a SIDS precaution that we should actually do. But if we need to promote drainage because of a lot of mucus coming up, especially if they're C-section babies, you may want to put them in a side-lying position so that it will drain out of their mouth. Be sure that we suction the pharynx before we suction the nasal passages. Basically, that means suction out the mouth before you suction out the nose. Because if you suction the nose, they're going to go, and whatever's in their mouth is going to go trailing right down into their lungs. And you don't want that to happen. Those long chapters, aren't they? Woohoo! Eye prophylaxis is mandatory. We usually use erythromycin ointment. You want to be sure that we place this in their eyes from the inner cannula to the outer cannula, and you want to pull down on the canthus and be sure you get it inside the lower eyelid. It doesn't do any good to squirt it on a closed eyeball, okay? If you squirt it on a baby's closed eye, it's not going to do you a bit of good. So I'm going to pull down on the lower lid from the inner canthus and go to the outer canthus and actually pocket it in that lower lid. That needs to be done within an hour, hour and a half of birth. This is to prevent blindness and eye infection that can be caused by chlamydia. Then, of course, if we have any infant who has experienced oxygen deprivation during labor, which means if we see a lot of late decelerations on the fetal monitor strip, we may see poor muscle tone in our babies. Infants who are actually in respiratory distress, they usually are very flaccid. They don't have much muscle tone at all. So if they've been stressed out and become hypoxic in utero, when they're born, they're going to be flaccid and assume the little frog leg position, and that's basically what it's going to be. They're not going to move around very much. You will also see this if you have a mother who's been on magnesium sulfate and the baby is born, can usually be respiratory distressed and definitely be lethargic, because what mag sulfate does is move muscle relaxer, relaxes mother's muscles. Remember, we have to check deep tendon reflexes on anybody on mag sulfate. Basically what we're looking at is that the baby gets the effects of the mag sulfate on their muscles as well. Blood glucose, less than 35 milligrams deciliter, or plasma concentration of 45 milligrams deciliter. So basically we have changed this to anything below 40 is hypoglycemia in the term infant, and 35 in the preterm infant. So blood glucose less than 35 is for your preterm infant, and less than 45 is for your term infant. You may have an asymptomatic baby, so you want to routinely check right after birth. We always do an AccuCheck and right after they're born. A lot of hospitals will do every 4 hours AccuChecks, which I think is very distressing for the baby. Um, if they are symptomatic, of course, we want to definitely check them. And these are the things that you will see: jitteriness, irregular respiratory effect, because they're using up their, basically, there's an underlying reason for all this to be happening. Either mom's diabetic, mom had D5W, baby was stressed out in utero. A lot of things that can cause all these to happen. And these are bad things. You get down here to twitching, eye rolling, and seizures. Usually hypoglycemia can be resolved with the first feeding. So if you have a breastfeeding mom whose baby's glucose, his term baby, is 40, you want to put the baby to breast right away. And then about 20 minutes after breastfeeding, you want to check the glucose again to make sure that the glucose has come up. So how do we collect these little specimens to do the glucose and such? Well, first of all, you want to warm the heel to dilate. You want to be very careful not to burn them. A lot of times we would put wet warmers that we've heated up. Now we have little chemical activator heel warmers that we put on there, but want to be very careful that we're not burning their heel. Be sure you wear your gloves. We don't want to have blood exposure. One of the most serious complications that we have with heel sticks is necrotizing osteochondritis. And this usually is a result from your lancet penetrating the bone of the infant's foot. So you want to be very careful about where you're going to stick the baby. There's a really good illustration in your book that shows you the outer aspects of where you should stick the baby's heel in order to get a good collection. It should be penetration should be no more than 2.4. So why are we telling you this? We used to do the sticks with a little blade that did not have a self-calculation on it. Now we have blades that are inside a little spring-loaded, just like our AccuChecks for our older patients. We now have the little heel stick that it will only go 2.4 millimeters deep, and it will only extend that far. So we don't really have to worry too much about the penetration, but we do have to worry about where we place our stick at. So we're going to draw that imaginary line between the fourth and the fifth toe, or between the large toe out, and we're going to run it parallel to the medial aspect or lateral aspect, and then we will stick in that area to get our blood sample. Our urine sample should always be examined by lab within 1 hour of collection. This little pity bag is a really good way to collect it, as long as you've cleaned the perineum, dried it off, make sure that everything is clean, and then you're going to stick this on here to make sure that you can collect it and make sure that the urine runs into the bag and not out. So you want to be sure and wash and clean the area really well, dry it off, stick on your adhesive. You can aspirate it directly from the diaper as long as you're not doing a culture. But if you're getting a urine because you're checking for an infection, you don't want to have any of these cotton ball diaper fibers in with your urine. If you're just doing a urine drug screen, you may be able to do that, but you need to have as much urine as you can. Urine drug screens are really only good if they're done with the first voiding. After the first voiding, then the baby's not ingesting any urine, any drug by himself, so it's not going to come out through the urine. It has to be with the first one. Meconium, it's different. The meconium is in there, and with several passings of the meconium will have whatever mom's ingested. When it starts turning transitional is when it's only one baby's ingested. So, and I'm going to stop here. I'll find my little stop button.